It's a real pleasure to introduce these esteemed panelists I have here with me today. Let me start with Huguette, who is from living in Ouagadougou and from Burkina Faso. She's the co-founder of and deputy director of the African Alliance of Digital Health Networks, an organization that helps develop digital skills and health leaders in Africa. Huguette, a warm welcome now to this panel. Antonio Russo is the lead for innovation with Deloitte in Switzerland, and he helps his clients to leverage the power of data and AI to deliver more customer-centric and innovative products that can catalyze their growth. So Antonio brings us more than 20 years experience in advising such companies in leveraging these innovative technologies, such as robotics, machine learning, and other. Sachit Balsari is assistant professor in emergency medicine at Harvard Medical School and in global health and population health at Harvard Chan. His research is focused on the application of mobile and cloud-based technologies to protect the health of populations marginalized by disasters and war. So warm welcome to you as well, Sachit and Antonio. Laura McGorman is the global policy lead for Facebook's Data for Good portfolio, which is focusing on sharing privacy-preserving data sets with nonprofits and researchers to really address crises around the world. Before that, Laura worked with the Obama administration at the US Department for Commerce, or Power, and also at the World Bank and USAID. Welcome, Laura. So I would say, let's give a round of applause to our great panel, but it's so different than having a panel discussion in live. But yeah, the question we want to address today is, what has COVID or these 9 past months taught us about how we can accelerate AI adoption in health? Because that's really the crucial question here. We all remember how in the end of last year, Blue Dot spotted this unusual cluster of pneumonias, and it was a real good example of an early AI intervention. And since then, AI has played a vital role already in responding and now slowly recovering from the pandemic. And in many aspects, in tracing, tracking, or predicting, or even in R&D to repurpose existing drugs or finding new drugs, and in accelerating diagnosis, automating healthcare delivery, name it, in all of these aspects. So it shows how much of a vital instrument AI is for every country that is battling this epidemic. So let's have a look of how we can make it even more successful and make sure that data, digital, and AI are helping us to build back better, as we hear in many cases, and avoid that we increase the digital divide around the world and that we increase inequities. We really need to avoid that. But we have a fantastic opportunity with AI to do so. So maybe we can start with Huguette from an African view. Huguette, what has these past months taught you about the issues in accelerating AI adoption in Africa?
Well, thank you, Anne, for covering that. What we've learned, most of the countries in Africa are a bit far from fully leveraging the capacity that currently exists in AI that countries outside of Africa are able to leverage right away. But what we've learned is the current situation forced many of our countries to really take a look and assess and understand the capacity in terms of data and health and the digital health maturity that's already in place. Upon those, we can build up to really being able to leverage what's available in AI currently. So we've learned again to really pay attention and understand our individual countries' capacities, identify where the gaps are, and as we're building up, we can prioritize these areas, because as we've learned that technology, the use of it in the health space is no longer a thing of luxury, which has been in for a while. It's become a necessity as things happen and we're all crippled and unable to move around. The only thing we had to help us reach people in every corner turned out to be technology. So that's one of the largest aspects that we've learned in terms of technology and health.
Thank you for that point. And I also, I very much agree that the telehealth has been very life-saving now, and innovation at the edge of these mature models was even very much impressive as well. But we've seen that this epidemic is the first one that is so data-driven, we get also in Africa. And I think you have been part of the polio eradication group in Africa, the one big light point of news in these past months. Congratulations. But this shows the importance of strong surveillance and response networks. So not only the data, but also what we do with the data is important. Can you just give us a very short feedback on how you participated in certifying Africa polio-free, for example?
Yes, exactly. And thank you for bringing that up. And when this I want to note that when this kicked off, it seemed like an impossible project. And it took a very small group of true believers at WHO, at a few other international organizations, and as well as people with an understanding of the African context to say we do need to do this and we can do this. And we turned to technology as it was really the only thing at that point in time to help us ensure that we could reach people in everywhere. The first thing we had to understand was just find out where the people were who needed to have access to vaccines. And so we made use of geospatial data, which has initially helped with the polio campaigns in Nigeria. And so we learned from that experience and scaled it initially in the Lake Chad region, and then in other parts of Africa where polio, wild derived polio, continued to be an issue. And so it took a lot of one of the things that took place within this wasn't just leveraging existing technology. The technology itself was really simple, but it was, as you said, knowing what to do with the data that we used. And it required efforts from social scientists, from local leaders, from community members, as well as from experts within and outside of Africa to come together and ensure that there was a data infrastructure that could be used by people at different levels. People with a variety of connectivity issues. And so that experience, if applied in the current pandemic or any other epidemics, can tell us that we don't have to wait for connectivity to be perfect. We don't have to wait for the entire continent to be online, that we could actually, if we incorporate perspectives from a variety of actors, we can figure out how to get the right type of technologies to different peoples and help meet their needs based on what their current resources are. And this is why AI should not be a limiting factor. It should, in fact, help us think about the possibilities. And projects like the polio work that we did, as well as others, trypanosomiasis, the Ebola epidemic is one where data really drove the strategy, should be encouraging us to keep moving forward and not to limit Africa's potential in terms of what the data that's collected on the ground can help the continent achieve.
That's such a positive message. Thank you for that, Huguette. I very much appreciate it. And it's so true. And Africa must be the most digitally savvy continent. You've been driving mobile finance, for example. Why don't we do it also for the health sector? It's really possible. Exactly. Thanks for the positive message. So Antonio, you've been working for many years with many different companies and trying to convince them to share their data, to make them interoperable so that we can have big data analytics done on it. But data are very often sitting in silos and not comparable or interoperable. So tell me a bit about your experiences in data sharing and how to make them interoperable during all those years that you worked with Deloitte.
Thank you, Anne. Very, very happy to share. So I think accessing and sharing data is a challenge. It is an opportunity at the same time. I think in a world where the entire health ecosystem is really striving for more patient centricity, I think having access and that data to be shared and interoperable across an ecosystem of partners becomes paramount. And I think we've seen the dial really moving, as part of COVID, where there's been a digital acceleration. And I think, you mentioned a few examples in Africa, but I think we've seen this, at large happening in multiple countries. When it comes to data, for AI to be effective, it needs good quality data. And I think, typically one challenge is the resistance to share. But on the other hand, it's also about sourcing the right information to solve the right problem. We've seen large-scale programs, data lakes programs turning into data swamps programs. So if you're not clear at the outset what you're trying to solve for, what kind of information you need, what's the right granularity and quality, then there's very little you can use. And it's very easy to lose yourself. I think you get also a good perspective about which data is accessible and needed at which level so that it's actionable or useful. So in the context of COVID, maybe a few examples, and focusing on recovery, we've built one of the most comprehensive searchable database, not only including health data, which is of course one of the biggest challenges associated with COVID, but also social and economic data. And we've used this asset to support global NGO and governments around the world to look at potential impacts and contrast and compare what countries have done and what were success or challenges in addressing and implementing some of the measures. So this is just one example where I think if we would just limit on health, we would probably not have the right answer, because we know about the social, economical, and health tensions that COVID has brought at political level, but of course also at health and economical level. And so I think this is a great example of trying to look for the right information. We found out that there's more available than we thought. I mean, that's the other thing. To Huguette's point earlier about don't give up and just believe in it. And we are now at a stage where we can even model potential health, economic, and social impact down at community level, or we could look at impact of COVID on unemployment rates and credit default, for example. So that's just an example to show the data can really help you to you can go relatively deep even at community level if you have the right quality and the right depth of information. And maybe
you already used that model to then propose recommendations to the community leaders to implement, or not yet?
So it's one of the assets we are using as part of our, I would say, global advisory, but it's definitely a key source of data where we have essentially all the countries in all the measures they've taken, okay, over time, and we can see what the impact of the measures have been. Now, every country has different, adherence to some of the restrictions that have been imposed. So all these things have been taken into that account, and we have an agent-based modeling that allows us to try to see what the impact would be. So yes, we have, but I would say just as an additional information for us to guide governments and NGOs around potential future impact of measures.
Yeah. Very interesting.
Maybe I'll allow very quickly on sharing data as well, which I think is also sort of part of the equation here. I think there is a general fear, and I think there's a few examples related to COVID. Now, we've done a piece of research where if physicians take really the time to understand, to explain understandably what the benefit is for the patient, the consent rate increases from 30 to 90%. And I think it's interesting to look at contact tracing hubs. I know there have been other sessions earlier and discuss the topic. Some research suggests that from 14 to 15% adoption, you already get some benefits, but to really get proper benefit, you probably need to be above 55, 56%. Now it's really interesting because if you look at, leave aside countries who have mandated it, and maybe where privacy and security has been overlooked. Countries that have made it free of use, even with communication campaigns, there are not many countries that have gone above 15%. I mean, literally, it's you can count it on your two hands. So I mean, this shows that there is still a lot of concerns on how data will be used or misused by whom and for what.
Yeah, absolutely. Thank you for that example. I think it's a very good one in the current situation we are. And it brings me to you, Sachit. You co-founded the COVID-19 Mobility Data Network, where you work together with 30 universities around the world and governments and tech companies to provide an analysis to governments and city governments as well on a daily basis of where we stand with COVID. And it really also applied your data to recommend the necessary responses to the pandemic. Can you tell us a bit about what worked well there and what didn't work well?
Yeah, I'd love to. Thank you for bringing that up, Anne. So the COVID-19 Mobility Data Network was a spontaneous coming together of research scientists, mostly epidemiologists who knew each other over the years, that had been working on infectious disease modeling, and especially with mobility data from social media companies and data from telephones, right? CDR data from your call records from cell phone towers. And we've been meeting since mid-March. It sort of spontaneously grew to include scientists from every continent. And the role that they saw was to serve as an intermediary between technology companies that were making these data available at a rate at which we have not seen before. Because these data are now available, and this was just a pivotal event which accelerated the use of these large mobility data sets. But the noise to signal ratio is really high. You have, every company put out these dashboards starting to score counties and cities in terms of their mobility and trying to sort of draw the relationship between that and the spread of the pandemic. And scientists sort of soon realized that they did not necessarily have a seat at the table or easy access to governments that were struggling to make sense out of this sort of avalanche of data that were suddenly available, saying these people are moving and those people are not. So the COVID-19 Mobility Data Network, which now has over 70 universities from around the world, the group continues to meet every Friday, basically is organized around three principles: data readiness, methods readiness, and translational readiness. The data readiness piece essentially tries to address the fact that the kinds of data that we need, as we just heard, the data are available, but to be able to get and access those data in a usable format in near real time when you have disasters and emergencies is nearly impossible unless you have pre-negotiated these conversations across both the public and the private sector. So we want to sort of push to say, how do you make these data available? And you'll hear from Laura, the next speaker, about how Facebook, for example, has applied privacy-preserving principles and new differential privacy technologies to make some of these data more readily available to a range of partners. And that's sort of the data readiness piece. The methods readiness is really the serious part, where you need trained scientists to say it's not just a matter of this county moving more than the other county. You really have to understand sort of the local context, be able to interpret the temporal and spatial scales across which these data are created, right? So data from Telenor or from Vodafone in India may not be presented in the same time intervals or the same geospatial units as data, say, from Facebook or from Google. And how do you, therefore, in real time, make sense of these data to make them interoperable? How do we develop standards such that when these data are reported, they're reported in a way in which scientists can use the data to compare across data sets to ensure that we know who is in and who is out? After all, these data represent people that use these devices, and in the majority of the developing world, we risk leaving large swaths of people out because they're not represented in these data. And so that is the methods piece. And the translational piece is something that you get alluded to, saying we have to understand what the local capacity is. You may present, the most sophisticated data and analysis, but you risk both you risk misinterpretation. And I'll give you an example. You can't come out and say, oh, County X is not physical distancing as much as County Y. You know, the Bronx and Queens and New York are moving around and Manhattan is not. The right response to that is not to send in, you know, the police force and discipline people, which is you know, commendably not what New York City did, but which is to say, how do we figure out why is it that these people are unable to physically distance? They understand the risk. Can we provide better social support structures so that folks can afford to stay at home if that is what is required of people to do? And we have seen the scenario play out differently around the world, where that sort of nuance in understanding why it is that people are able to distance or not able to distance or stay at home for an extended period of time can best be supported by, you know, protection strategies. So it's really that is what the network was about, and we continue to meet every Friday afternoon and work with local city and state governments to sort of work through these issues of data methods and translational readiness. The network now expands to a larger platform called Crisis Ready, where we have begun to work both on population displacements with the hurricanes and the wildfires in the United States. I'll pause there, Anne.
Thank you, Sajid. And this is absolutely key that you bring out so many issues. You've been working together with the COVID Mobility Data Network, and you've generating a lot of mobility data at Facebook. So what are some of the issues you've faced and have been able to address, and how do you see that moving forward? The other issues that Sajid was mentioning, like the privacy issues or the representativeness of the data.
Thank you so much, Anne, and thanks so much for having me. It's great to have Sajid, who I work with so closely, tell the story of how we're trying to really deliver life-saving service delivery with more informed insights from platforms like Facebook. So I think rather than talk about the data itself, I want to talk about some of the privacy approaches and then really the collaboration model that Sajid was speaking to, because I think that's in many ways more important than the data sets themselves. In terms of privacy preservation, when we started sharing mobility data, it was actually in 2017, the launch of our Data for Good program focused on trying to track things like population evacuations when mandatory evacuation orders were put in place during things like wildfires or hurricanes. We were also using this information at scale to figure out if there were populations that had been displaced by large-scale events like Hurricane Maria. And then in 2019, we found, by working very closely with the health research community, that aggregated location data could be very helpful in terms of trying to track the pathways of infectious disease. So in the early days of what we call disease prevention maps, we were working with researchers to try to understand how mobility data might be useful for tracking things like a cholera outbreak or a measles outbreak. Of course, little did we know there was going to be a global pandemic that would hit the world, for which the major interventions were actually these physical distancing measures and stay-at-home orders. And so the demand for mobility data went insanely through the roof. We had previously made this information only available through license agreement. And we had started the year 2020 with around 100 partners, 100 universities and nonprofits we were working with. Right now, we're about at 400 partners. So we quadrupled our international reach, and we have partners in every continent and every region of the world. But we also, as Sajid mentioned, realized that having individual institutions sign license agreements was still slowing us down. The desire for this information was so widespread, given the need to physically distance in nearly every country in the world. And so we applied what's called differential privacy, which is essentially adding a discrete amount of noise to our mobility data sets. And we shared that information aggregated at a county level now publicly so that anyone can track how physical distancing and stay-at-home orders are sort of progressing at the county level around the world. And I think that while this is something that I remain very proud of, I think the work that Sajid and Caroline Buckey and Andrew Schroeder are doing through the Mobility Data Network is even more important than the actual data delivery itself, because what I've found is that as we continue to share more and more data in real time, it really is the collaboration model and the translational piece that's the only way that impact is actually delivered on the ground. Data is really just the start. And I always think about the Agile Manifesto saying that it's people over process. Who are the relationships that are help driving decision-making on the ground? What are the processes whereby decisions are being made? If something like real-time mobility data is not typically an input into a decision-making process, just because mobility data is now available, do we anticipate that decision-making process all of a sudden incorporates those insights? In most cases, the answer would be no. And so we've also been trying to do research on our own workflows and our own partnerships to better understand from this sort of data delivery moment all the way to a decision-making process on the ground in a room, potentially with key stakeholders of which a data team is not even a part. What is that workflow, and where do the data sets actually make a difference? Because I think it's one thing to have partnerships spun up around the world, but it's quite another to have successfully changed public policy or successfully changed community level behavior with data. And that's really where
they get used for. Yeah, absolutely.
That's right.
What the data get used for is your goal overall. But that's a very important point. And it shows again, we also say very often, it's not the scientific innovation necessarily, or in this case, the technology innovation that makes a difference, but the way that it's deployed or integrated.
That's right.
And one question I got from the audience here is, how can we accelerate AI deployment across health and care? If you think about Europe, that is going to come out with a new AI regulatory framework only in a few years from now, how can we deploy it faster? Because it's now that we need the adoption of AI. So according to you, if I may ask you each to give a very short answer to that, what are the further constraints for adoption of AI? Or if you prefer, also giving an example of what you think that this COVID crisis has accelerated that will stick with us after the pandemic. You can choose which one you answer, but you get 1 minute because our time is almost up. Brigitte, you want to go first?
Sure. I think for us, in terms of this came up with the panels and discussions that we've had around Africa today. There still remains to be the connectivity issue. For this to even become a reality and something that can move beyond research level to become usable, there's got to be the connectivity issue that needs to be addressed. But part of that will be addressed once we get the regulatory environment involved. So the challenge that I see all over Africa is to bridge the understanding of technology and move it from the scientific and the technological community where it exists into the governing spaces, and have government officials understand the potential of technology in addressing the problems they've been battling to address for years and years. For some of our countries, since we became independent, we haven't figured out how to manage our health systems. So that I will say is a key factor. We can advance all we want, but until we get those who have the mandate to make decisions for the in place of the population,
it's key.
Whatever advances are made will be blocked. So
it's exactly the same message that we have in our report of the Broadband Commission Sustainable Development Working Group on AI in Health that I presented this morning. It's really the same thing. You need to have that visionary leadership, or it won't get deployed. We won't get any impact of the solution. And the ideal scenario is that there is a national coordination, keeping the driver's seat to decide what AI solutions are needed most urgently. And then you have a really efficient AI solutions introduced. But Antonio, what would for you be the biggest constraint in there?
Well, I think the constraint and the opportunity at the same time for me is collaboration, really. I think if you work collaboratively around a common issue, then somehow it will unfold from there. Regulatory framework will be put in place because you have, and there are very concrete examples. Even governments today, you can see tensions because, as we said earlier, COVID has society, health, and economic impact related. And so just get all that together in general in the future of health, if you want, and if it's about general health for the entire population, I think it would be great to see increased collaboration between life science company, care provider, and then the payer side of things. And I think it's very difficult. Everyone is trying to optimize in their own garden, and I think that the greatest example we see is that where this collaboration starts happening.
Beautiful. Yes, exactly. And multi-sector collaborations are key for anything we want to achieve in global health, and specifically hard and urgently needed with all the challenges we face. It's a key factor. You're absolutely right. Laura, anything to add as constraints? Or yeah, Sachit, I will bring you last then, sorry.
Sure. Yeah, I think it's twofold. I think that on the data provider side, I think we really need to be focused. They say good product development is being obsessed with your users. I always say that when you're creating these foundational data sets, you need to treat it like a product development lifecycle and really focus on the users. So I think sometimes these basic requirements, like easy to read metadata, files that are easy to download and then incorporate with other data sets that are already part of your workflow. I think as data providers, we need to be really focused on solving big problems and also really focusing on the usability of our data sets. I also think on the flip side of that, there is a bunch of we call it data literacy. Like I'll even admit that sometimes the data sets that Facebook Data for Good provides, when I try to do my own analysis, I'm asking our data scientists questions myself. And so, if I experience the pain of a user myself, then it goes to show how much we still have to achieve in terms of broad-based training and things like GIS, broad-based training and things like Python, R, and the necessary systems to make use of these data sets. And so I think data literacy is a little bit of a catch-all, but I do think that just really broadening the availability of those types of tools and skills around the world is, it's not a sexy thing, but it's critical.
Yeah, absolutely. And for you, Sachit, what would it be?
I'm thinking of the webinars that Novartis Foundation has been organizing with the Harvard Global Health Institute and the conversations that we've had there. And you constantly hear from clinicians that all this excitement at the 30,000-foot level is great, but in the majority of the developing world, and I'll restrict my remarks to clinical data, we forget how poor the quality of data is, right? It's community health workers running around with these tablet computers that we have straddled them with, often several tablet computers for several different vertical programs, struggling with radio buttons with bad internet connectivity, as Huguette pointed out, trying to generate what essentially then becomes the backbone of the clinical data on which we want to build these AI algorithms. And I think we need to take a deep breath, a step back, and make heavy investments in making sure that these foundational data, where they're being generated in the villages, in the slums, in the small towns of the majority of the world, are actually smaller quantity of data is fine, but reliable, replicable, high quality data is what we need.
Very important. And it's so fascinating how you all bring out the different constraints that make the whole roadmap to maturity for AI in health that we have just described, based on a landscape of 300 AI use cases that are already making an impact in health. And they are all around people and workforce, that we have to increase these digital skills and the possibilities for education in data science and AI, about data and connectivity, the quality and interoperability of data, but specifically the broadband connectivity as well, obviously, is key. The governance and regulatory frameworks are absolutely essential, and the fact that all solutions have to be designed around an existing need, not around something that is well intended but doesn't correspond to the priority, and has to be human-centered, keeping the needs of the users in mind, like you said, Laura. And then there's the partnerships piece, which you brought out, Antonio, which is so important, because if governments don't streamline a coordination of all these partners bringing these fabulous innovations and trying to integrate them in the health systems, we end up with a fragmented landscape, just like we did in the beginning of the digital era, if you remember, in many countries around the world. And lastly, the sixth theme where a government needs to invest in to advance on its maturity to AI for health is really sustainable business models. If there's no money from or no funding from the government for the AI introduction in the health system, they have to open up to innovative ways of incentivizing innovations, or innovative ways of monetizing data and their assets, or innovative mechanisms of financing. So all of these six themes are equally important, and the issues you mentioned are absolutely the first and foremost to be addressed by every country. So with this, I want to thank you all for the very interesting and insightful discussion. I thought it was very rich as content, and we can all move forward and think a bit further of how we will exploit our learnings from the COVID pandemic to make a better world with better connectivity and better data and everything better for better health. Thank you so much for your participation.